Thank you, Krishna sir. Thank you, chairpersons, for that introduction, and thank you, ISOD Scientific Committee, for having me here. So I'm the last batsman, and I'm what is keeping you away from the lunch. So let me just start with my topic. So approach to a patient with a failing kidney allograft. So this is a gloomy topic. I mean, what we are looking at is a failing kidney. The hopes are all going out. The patient is looking at dialysis, and so how do we manage? And mind you, it's not a one inflection point. So it's a continuous process. So sometimes it's a problem where to call it failing, where to intervene. So that's sometimes a problem. So first, what it brings us is, what is a failing graft? So a failing graft is characterized by three things. So that is how the American Society of Transplantation has defined it in 2021. So transplants are there for so long, and it has taken us so many years to find a point that we want to define failing graft. So stable but low allograft function. So somewhere around, say, a person lurking at around 3 milligrams per deciliter of creatinine. So that's a failing graft. Declining function, where there is reversible and progressive loss of the kidney function, where it is anticipated that this person will need some other form of RRT, maybe dialysis or something, by 1 year, and the return to a kidney replacement therapy like dialysis. So these are how the American Society has defined it. There was actually a 2022 KDIGO controversies conference, where they have taken this first thing, that stable but low allograft function. Is that a failing allograft? Because now with more and more elderly donors, more and more ECD donors, even DCD donors coming into the picture, so defining a allograft with a bad creatinine, say around 2.5, as a failing allograft may have its consequences on the long-term acceptability of those grafts. So they have thought that maybe we should not talk of the stable grafts, but anything that is falling and is progressive, that we should definitely take as the failing allograft. So these are the two caveats that we need to remember. Now, problem statement, it is definitely not uncommon. What we have seen is that at around, say, 5 years, 20% of grafts will fail, and at around 10 years, 50% of grafts will fail. So in the short term, most of the outcomes have improved with better CNI, tacrolimus being available, good induction, and good pre-op management and everything. So that has, but we all know that the long-term consequences, the long-term outcomes of transplant has not changed much. So much so that around 11% of all incident patients in the US in 2023 were persons with failed allografts, and it is the fourth most common cause of initiation of dialysis. Now, I'll want all of you to meet Raju Bhai. So it's a 35-year-old male who was diagnosed with IgA nephropathy. Living donor kidney transplantation in 2016. Mother was the donor. She was 58 years at that time. There is no history of sensitization, basiliximab induction, and triple immunosuppression. He was fairly compliant. Now look at the progression of events. So in 2018 he had a rejection. Creatinine jumped from 1.3 baseline to around 2.8. He had a biopsy which had some changes of chronic CNI toxicity. There was some mesangial deposits also. So these are features that tell us that, okay, this graft is not going to do extremely well. So he received pulse steroid, Plex, IVIG as is the routine. So creatinine came down to around 1.3. Subsequently had multiple issues, pulmonary tuberculosis, COVID-19 and everything. So again a repeat biopsy was done in 2023. The creatinine at that time was 2.4, chronic ABMR, chronic CNI toxicity. And then the creatinine has seen an uptrend, and now it is around 5.2. So what are Raju Bhai's typical questions? So दवा से ठीक हो जाएगी, कुछ खतरा तो नहीं है. So these are questions we don't want to listen to, because there is no clear explanation to it. But if you take them one by one and think of what actually Raju Bhai is asking and what is the relevance in our terms, so dawa se theek ho jayegi is actually means, is there a component of reversibility? Are we looking at something that can be reversed? So that's a valid question. Similarly, kuch khatra to nahi hai. Of course khatra hai, because the outcomes of dialysis after graft failure is not good. It is far worse. I'll show you that. So kidney में infection हो गया है. These are common questions that they like. What is the etiology? Obviously infection is not there, but what is the etiology? Dialysis तो नहीं लग जाएगा. They are very afraid of dialysis. So preparation for dialysis is a must. We need to tell him that yes, dialysis लगेगा, and we need to be preparing him for that. very important question, fill me wala. Kitna time hai mere paas? So we need a predictor model to tell him that yes, you are going to need a dialysis at say 15 months, 16 months, whatever. फिर से transplant हो सकता है? That's a question. My mother donated last time. Father is aged. What do I do? What do I do? So planning for a living donor or a deceased donor transplant, that's important. And then how do you manage this transplant in the immunosuppression in the meantime if he's actually looking at a transplant? पुरानी किडनी निकाल देनी पड़ेगी. That's another question. So are we looking at graft nephrectomy for some reason? So these are actually very relevant questions that Raju is putting to us. So the first thing is establishing an irreversibility. For most cases, it's very clear because we know the creatinine trends. We have seen the previous biopsies. We can do a Doppler and find out a lot of things. Response to the treatment we have already seen, so it's not working. And then we have other things which we typically miss: anemia, secondary hyperparathyroidism, bad phosphate control. So we know that this is a CKD for no doubt. The etiological diagnosis, that is very important because the approach somehow manages, it boils down to what is happening in the kidney. Is it a chronic ABMR? Is it a T-cell mediated rejection? Or just CNI toxicity? Maybe an infection like BKV nephropathy, de novo glomerular disease. So we have this general approach, the head of the screwdriver, and those pointy things where we can change the way we approach that kidney. Now, this is Raju in 2016, and this is what he has become in 2025. Seems like the same man, but is it same? So, in 2016, he had planted a small sapling with hope of doing good with that. So, what has happened is that it's a big tree now, but it's like giving the wrong fruits. What has happened to him? Age has increased. Obesity has increased. He has had so many infections in the past. Comorbidities have increased. Drug-related side effects are there. And this graft failure comes with emotional trauma, a financial burden, social burden. Now he's married with 2 children. There is a risk of malignancy. So all of that has changed. So by no stretch of imagination, these guys could be more different. So what are the outcomes of a person on dialysis? So we have 2 large registry data, DOP study and the SRTR study. They've shown that the all-cause mortality in the DOP study, it was 1.3 times. Cardiovascular was 1.5 times, and infection-related was around 3 times higher. Similarly, in the SRTR, all-cause mortality was is around 78% higher. And this was irrespective of age and diabetes. So the graft, the immunosuppression, they are playing a role in it. Now, prognostication models. How do we tell Raju bhai ki aapke paas kitna time hai? So the standard thing would be to look at the creatinine trend. So, but it's kind of non-specific because it keeps on jumping which way, any which ways, and it's non-linear. It doesn't. We don't know because from 2 to 3 and 3 to 5 and then 5 to 10 doesn't take. I mean, it's very unpredictable. So there is a lot of visit-to-visit variation, lab-to-lab variation, methodology variations are there. EGFR, so none of the EGFR formulas have been validated for the transplant population, but still they do reasonably well. Now, KDCO has recommended in this controversy conference that we need newer formulas. Now, proteinuria has been found to be a stronger risk factor than a biopsy, anti-HLA antibodies, and so many other clinical factors. So proteinuria is one of the important things. We can look at the old biopsies and maybe do a protocol biopsy, but in a failing graft, doing a repeated biopsy hardly gives us anything. So that's like hardly used. We can monitor the DSA trends, so that will give us some clue of what is going to happen in the near future. And then we can collate all of these and take the patient and donor factors, something like a living KDPI, what was happening. So we can tell them that. What is new is a paper by Alexander Lupe and his group, as a large group, and what they have found, they have developed this iBox tool where with 7,500 patients, and it's a multi-center trial, they took in around 50 parameters, evaluated, and they found that 8 predictors are there which are significantly going to predict the way your graft is going to behave. So time after transplantation, EGFR at this time, proteinuria, biopsy features like chronic glomerular lesions, I plus T, G plus PTC, IFTA, and anti-HLA antibodies. So now they put all of this and they tried to predict the 3-year, 5-year, 7-year survivals. And this was again validated outside with another 4,000 patients, and it had a 80 to 81% accuracy based on the validation cohort. So like this is the result that will give is a 3-year survival of say 90%, 77.5 at 5 years, and 66. So this has been validated in grafts with normal graft function, poor graft function, and actually a failing graft. So how do you prepare a patient who is going to need dialysis in the near future? So like the doctor is actually looking away from what he's supposed to do, like he's thinking whether should I look at changing the drugs, doing a repeat biopsy, adding some adjuvant drug to save that kidney. So the entire focus is towards saving the graft. So we lose sight of the other things that are to be managed better. So it has been seen that even though most of these patients with graft failure are being managed by nephrologists and transplant nephrologists at that, they are less likely to have a preemptive transplant. They are less likely to have a preemptive DDKT registration if that is being allowed. They are less likely to start a dialysis with the fistula. They are typically going to have a catheter in situ when they get a dialysis. They are rarely offered a PD. They rarely get a ESA support even when the anemia is developing. They are nutritionally poor, sarcopenic, and they often crash land into a dialysis center, starting dialysis with a catheter as high as 66%. And mind you, this 66% is when some of these patients actually have a functioning graft, functioning fistula from the last time. So even then, the overall rates are around just 66%. They have worse anemia, phosphate control, lower bicarbs, and are less likely to receive medicines like ACE and ARB. So after that, it's always trying to play catch up. Now, outside of India, there is a big difference between a transplant nephrologist and a general nephrologist. Luckily, in India, we are the one and the same people. So in India, transplant nephrologist is also the CKD nephrologist, and yet it is very easy to lose sight of what you are looking at. So what can we do? We can establish some low clearance transplant units where you have social workers, counselors, a multidisciplinary team. We can use a pre-designed checklist. We can use CKD parameters in the routine visits, which is typically not done in the post-transplant OPDs. Two important issues are to discuss the dialysis modality and when to initiate dialysis. Now, the choice of modality is by and large very non-equivocal. So it is like there is hardly any difference between starting a PD or starting a HD. It is quite possible to put in a PD catheter in a patient with a failing graft and initiate on dialysis PD. So it mostly becomes center choices, patient choices, and the financial services that are available. Late versus early initiation of dialysis. This is just data that has come up that the patients who are initiated on dialysis early tend to do worse. Probably it is not because of the dialysis initiation, but the subset of the patients who need this dialysis. So again, is retransplant the best treatment? He asked, like, वापस transplant करना पड़ेगा? So this is the BTS guideline, 2014 although. So what they have recommended is that for almost all patients, retransplant is the best possible option for survival and quality of life. Only exception is where the kidney fails within 1 year. So these patients with a fulminant course, they may require a little bit of time before they go on to transplantation. And with every year on the wait list, so there are 11% more chances of an acute rejection like event happening, and more graft loss and higher all-cause mortality after the transplant. So is the retransplant the answer? Yes, unless we are looking at situations like graft loss within 1 year, severe untreatable comorbidities, maybe very high age or something, active infections, active malignancy, and frailty. We have been discussing this all throughout the last 2 days. Now, typical situations where we post-transplant lymphoproliferative disorders, graft loss due to a fulminant genetic-based complement-mediated TMA, if the first graft had been lost there, an anti-GBM after Alport, and a malignant FSGS recurrence. So these are very tricky situations where it has to be individualized and decisions have to be taken. Now, relisting for transplant. What has happened is the number of transplants. This is on the left side. We have the number of registrations. So that has remained fairly stable in the patients who are having who have a graft failure. So overall, the percentage is decreasing, and in actual transplants, although the absolute numbers are increasing, the percentage of grafts that are going to a retransplant patient are actually falling. So why are these patients who have graft failure not getting kidneys? Because awareness is probably not an option, because they already know, they are in the system, they know how it works. So it is probably because we as nephrologists are failing in our task to tell them that you need a transplant and you need to go and register. The other problems are sensitization. Like what do you do with the immunosuppression? So the policy is to decrease it. And sensitization, what is the risk of decreasing? They may get sensitized. There may be loss of RRS. the residual renal function, they may be graft intolerant, and if we withdraw steroids, there may be adrenal insufficiency. The benefit is lesser infection, lesser malignancy, diabetes goes off, CV mortality goes off, and the cost of getting a transplant is lesser. But how much to do? How fast? So there are a lot of determinants. So retransplant scenario, they need to preserve the RR residual renal functions, the previous sensitization, the HLA1 epaulette matches, and everything. So this is a cartoon that has been given by the by S. Davis and Mohan, Sumit Mohan in CJASN 22. So what we see here, if there is a transplant that is going to happen in the next 1 year, what we need to do is continue the immunosuppression, maybe lower it by a little bit, say antimetabolite cutting down. If we are looking at a disease owner enrollment, or like we are not clear about the transplant scenario, then the first option would be to decrease the CNI, and the second the first option would be to decrease the antimetabolite and then slowly taper away, or the other option would be to taper the antimetabolite first. So predominantly what is being done is the CNI is being kept and the antimetabolite is being taken off. Now late transfer to belatacept, which is a non-nephrotoxic option, is also one of the options. Now somebody might ask, like, CNIs are nephrotoxic. Why do you want to keep the CNIs? Why not take away the CNIs, keep the antimetabolite? So there is a lot of data that has come up that once you take the MMF off, it predisposes the person to a lot of early rejections, the development of DSAs, and rapid loss of graft function. So some of these studies are in different scenarios where they have in patients with stable graft, they have tried to take off CNIs, like as Dr. Divesh very eloquently told us, or CNIs withdrawal after lymphoproliferative. So none of the data is direct, but we have enough evidence to tell you that the continuation of CNI probably gives the best option for the patients who are having a failing allograft. Now, I took this WhatsApp consensus. I sent this question out, poll out to a lot of WhatsApp groups that we have. Of 91% respondents, what was the general trend is nobody wants to take off prednisolone. They all want to taper MMF and azathioprine first, and majority want to taper off CNI or azathioprine a little bit, and most of the patient will be left with a little bit of steroid only. So that's the trend in India. What remains is a subset of patients with active infections, maybe high risk for a transplant and everything. So in those patients, maybe complete withdrawal of all immunosuppression may be a good option. The last part is the allograft nephrectomy. So it's a risky thing, risky surgery. I've never seen a surgeon, be more afraid of anything else rather than a graft nephrectomy, like Jamal sir was actually saying. So these are actually problematic surgeries with hemorrhage, infections. What are the classic indications? Indications are hemorrhage, infection, graft intolerance syndrome, necrose graft loss, very early graft loss within 1 year, and the operative mortality is around 1 to 11% based upon the indication for which it's being done. There is a lot of intraoperative bleeding, intestinal injury, patient can go into DIC. There is an option of percutaneous graft embolization using the intervention radiology team. Now, what are the considerations before we do that? So what has been shown is if the graft is left in place, the patients have worse anemia, more erythropoietin resistance, lower serum albumin, higher inflammatory markers, and there is a higher risk of all-cause mortality. So in summary, the patient's journey is not a single stop. It's not a one-size-fit-all kind of thing. So medical and surgical management, psychological support, that is supposed to be the beginning. We need to individualize all these patients, understand what is their problem, the concerns, address them one by one. And the options are conservative care, very early push towards retransplantation, because that is probably the best option that we have, prepare them for dialysis, and then find a acceptable path. Thank you.